Report. This is a town hall live from Panari, and let me tell you, during that break, so much contributions and discussions around health happening here. I hope we'll be able to get them all through onto TV before our time is up. Now, just before the break, we had Angelina Shikanda, who is a program development manager at the Center for Rights, Education and Awareness, with a comment or a question. Angelina, let's go over to you now.
Thank you, Igor. My question is to the CS and also to Dr. Nyikal.
You have promoted her, CAS.
CAS, yes. The issue is around what the government has committed. Our president was very bold in making commitments through the GF around addressing gender-based violence, and there is a roadmap that is in place. The question is, what next? Being aware that next year we're having our elections and there are opportunities for changes to happen. Where are we in that regard so that a woman out there in Kilifi knows how they can be able to access support? And secondly is the issue of prevention. To Dr. Nyikal, what are we doing to make sure that prevention becomes a core mandate in terms of addressing health? Because prevention, as we say, is always better than cure. Where is the marketing strategy around UHC? Because we saw it at COVID. Every other phone, every other space we had, everybody knows about COVID. Where is the mechanism to do the same around the most basic of health issues that we are grappling with? Where, if we can have a similar strategy around all the health issues that we are grappling with, I think we can be able to save as many lives as possible. As we speak, we are dealing with the issues of teenage pregnancies that are very high in our counties. We were just in Mary the other day, and they were counting 14,000 girls who are pregnant. Where is the space for them to access healthcare, knowing that many of them are not even informed about NHIF, they're not covered by their parents on NHIF. Where is the space? They're scared to go to the facilities because it's not friendly. Where are the mechanisms to make this a reality? Thank you.
Thank you. Thank you. The panelists will note that. Let's get, I think, Angela Ngoko, who's the Deputy CEO, White Ribbon Alliance. Let's hear your comment or question. Keep it brief, please.
Thank you. I'm actually sitting here and I'm puzzled because we are talking about a democracy, that is Kenya, government of the people, by the people, for the people. But I've not heard anyone talk about where is the place of citizens in shaping that UHC. The second thing that I'm really puzzled about, and I'm so glad that we're talking about so many policies and all these frameworks and the like, but we know the aspects of UHC around quality, equity, and accountability. Who holds who accountable at the end of the day? I'll also touch on health literacy. We are hearing about issues around people are not aware, people are not aware, people are not aware. But we know literacy only comes from, if we look at health as a whole, not as curative. All I'm hearing on that panel is curative, curative, curative. Where is prevention and promotion? Where is rehabilitative? Where is palliative at the end of the day? Because we either pay less now or pay more later. The non-communicable diseases, the burden is increasing. The communicable diseases burden is increasing. Where is the role of prevention, promotion, and where is there no investment in that? Because everything looks at curative. The people are left out. 80% of the experts of care who can actually be able to tell Kasa Mwangangi that healthcare is quality or not are missing. They are 80%, they are the real experts, the users of care. Where are they in this space? Because no one has talked about them. Everything is about the supply side, supply side, supply side. Where is the voice of the demand side? Because unless we are keen to listen to the voice of the citizen, of that mother, of that girl, of that man, or that woman living disability, we will not understand what quality means to them. Accountability, who holds the two aspects of the government accountable to the care that we are receiving? Does it mean that care should be whatever it should be? And I will finish by saying this, and and pardon me for saying it. The day I will see our elected and our government officials going to public facilities, that is the day myself as Angela and the other people in the other different places, we will actually know that we have quality services. So why are they going to private when you are telling us to go to public? Where is the gap? And why is our public sector not having what it takes for that all of you can also be able to go to that place? Thank you, Maura.
Okay, interesting question. I thought that's where the audience would clap, but I won't push them too much. The beauty is I have 4 leaders here. The leads tell us where they go to get treated. Now, very briefly, there's a lady here and a gentleman at the back. I'll give you each 30 seconds. I'll come to the rest of you shortly. Let's start with you, please. Just introduce yourself and your question or comment briefly.
My name is Evelyn Boa, and my question is regards to UHC. Do you have budget allocated and any implementation committee regards to that? Thank you.
Thank you. That's how we like it, short and to the point. Please introduce yourself.
Yes, thank you, Wahiga. My name is Peterson Washira. I'm the chairman for Kenya Union of Clinic Officers, and I also chair the caucus of the unions in the health sector. And I'm very happy that today we have a very powerful panel here. That is the Ministry and Parliamentary Health Committee. And so we know that they can actually be able to sort our issues, or they can take them forward.
What's your question or comment?
Let me start from, I'll start with a comment. Please, Wahiga, allow me some time because I'm representing the voice of the health workers.
Please, briefly, please.
Yeah, the reality on the ground is that when you're saying that we want people to access UHC, we must be able to break down this access. Access does not mean being next to a health facility or accessing that health facility. It means when I get into that health facility, will I be attended in time? And that cannot happen now because we are not actually even meeting half of our staffing norms. In 2014, we made staffing norms and standards for health, meaning that for every level of facility, we needed this number of healthcare workers to be able to see Kenyans and to ensure that they get the quality and they access those services. When the county governments came into place, they have said that the staffing norms and standards are overambitious. So they are not utilizing them. As we stand today, our government does not know how many health workers they need per level of facility because there is no staffing norms and standards in place. And the one that was there, the governors have said that they're overambitious and they cannot use them. So Kenyans are coming to us as healthcare workers. We have a dire shortage. By the time you are coming to me, I'm already fatigued. So even if you see me, and I have already seen 50 patients, you are not going to access quality service of healthcare because by the time you are getting into that door, I want you to get out because I'm fatigued. I will not be able to see you in the right way, and I will not be able to make a sound diagnosis, and so you're going into complications. So you are not going to access the service that you're supposed to access. So what is the solution? The solution we are saying,
are you asking what is the solution, or you give us the solution?
Yes, the same way.
Yes, I'm giving you another 10 seconds.
Yes, please, the same way that
yes.
Okay, thank you, Wahiga. The same way that we employ the disciplined forces and teachers every year. Why is it that as a country we cannot employ healthcare workers every year so that we meet the staffing norms and standards, and we have a budget to accompany that to ensure that it happens? Thank you.
I'll pause to allow my panelists to respond as Dr. Mwangangi and Dr. Nyikal figure out how they'll summarize their responses. Senator Kasanga, you've had a mention of mental health, mental wellness, and you can talk about that. You chaired a committee on the same, and also the question of workers in the counties and the reality of what people actually find. I can give you a chance to respond now, Senator.
Yeah, thank you so much. Dr. Mwangangi did canvass quite a bit on the mental health, but she left out just one important step that we've achieved as a country, and that is the Mental Health Amendment Bill that was passed in Senate and is now under consideration by the committee at the National Assembly. And that's a very big step. And really the biggest import of that bill is to mainstream mental health into the primary health care. We're not looking to separate because of the stigma, because of accessibility and many other issues. We're looking to streamline. So you can access services even at, level 1, level 2, level 3, level 4. That is the whole idea behind the bill, alongside many other items. It's a very comprehensive bill. It deals with also the rights of people living with mental illnesses. And it gives the task of the things that you're talking about, creation of awareness, reaching out to people, the issues of rehabilitation, the issues of caregiving, preventative, all that conversation, including education for early childhood, is all resident at the county because health is a devolved system. So the bill gives that task really to the county. So the issues, the things that you're doing as Oxfam on the ground is actually work that the county government should be doing and should have a battalion of mental health workers, either, community health workers doing, the sort of things that you're doing. And that is where the vision is taking us once that bill sees the light of day. So that's a big step alongside with everything else that the ministry, of course, is doing. And to answer our doctor our unionists in the panel today, in the crowd today.
As you also tell us, when was the last time you visited a public health facility as a leader here today?
Actually.
Please proceed.
Well, believe it or not, I actually see doctors at Kenyatta Hospital. My daughters go to their doctors there, and they're the best pediatricians in Kenyatta Hospital.
Okay.
That's the truth.
Okay.
That's the truth, absolutely. Even my own dermatologist from Kenyatta Hospital, he's now the CEO, I think, of Kenyatta Hospital, Dr. Kamuri. I'd been seeing Dr. Kamuri all through my childhood and my teenage, dealing with my acne, and you can see he's done a good job so far. Yes, he's done a good job. So I believe in fact, I stand with Dr. Nyikal. When we were having tea, we said it, that really, healthcare should not be a business. That's the truth. Our public health facilities should be the marker. You know, something like Mathare, believe it or not, Mathare, which is a training facility as well, has the best mental health practitioners in the entire region. Yeah, it is just a stigma, and the fact that we've not invested in our facility, that is, we are shooting ourselves in the foot, but we have the best, you know, access there for healthcare, for mental health, and that's the truth. So I am a believer of public health, and I stand with Honorable Dr. Nyikal here that is the direction we should go. I am a supporter of the UNHC, I'm the supporter of NHIF, and I believe that is the right vision, that is the right direction we are going as a nation.
Okay.
And for the healthcare workers, you know, health is a devolved system. So even the solution that you're trying to give may be a bit difficult under the current, you know, dispensation on how we have organized ourselves as under the Constitution, that you will still be under the governors. And really now is a question of accountability. Somebody raised an issue about accountability. I think the lady over there, you raised the issue of accountability. How do you hold, how do you hold, you know, your governance structures to accountability? And this is where it comes to. When we went round to the counties during our ad hoc committee, we raised a lot of issues on how the healthcare workers were being handled at a time of COVID when they were first line workers. Why didn't they have this? Why were their statutory deductions not being done? And that is what we are supposed to do as parliamentarians and even as citizens. And citizens, how do you engage? You have a duty as a citizen. You know, I was one of the proponents of the BBI because the BBI was adding tasks to the citizen. You cannot sit and wait and say, where is my space? You have to rise up and realize you have mechanisms. Even now you have mechanisms in which you can engage your governance structures. In Parliament, we are constantly receiving petitions. Anyone can petition the Parliament. It is your right. You can petition. You can petition as a union. You can raise questions through your parliamentarians or through any other means. You can engage with the documents I was talking about here. The Auditor General reports are public documents. How many of you take time to look at some of these things so that you can raise the questions as citizens? I'm not saying that we are doing everything. No, I'm saying, yes, there are still gaps. But for accountability purposes and the question that was raised by one of you, even citizens, there's a duty you have.
Thank you, Senator, for that. Let me allow PS to weigh in. PS, questions were raised about access to healthcare in some of the largest counties that we have in this country, where someone thinks or knows the nearest health facility is 100 kilometers, 200 kilometers away from them. What do we do about that situation?
Okay, thank you so much, Maura. I think I can say that before devolution, I think that was the situation, but at least after the devolution, there are some changes. If you take some counties like...
Okay, I apologize. We seem to have a slight challenge with your microphone. Let me get that sorted as I pick a question. Just hang on there, don't worry, we'll get that fixed. Please introduce yourself, brief question or comment, tafadhali.
Good evening. My name is Violet Mbiti, and my question is regards to sexual reproductive health. When it comes to domestic allocation towards health, you find that the government has not really increased allocation there.
Please move the microphone closer to you.
And yet international donors are withdrawing funds even towards health. So I'd like to know from Dr. Nyikal and CS Mwangangi, what measures are they doing to increase domestic allocations towards health? And also, even during this time of COVID-19, we've seen that there's also been reduction in funds towards sexual reproductive health. And as a result, there are no family planning supplies in the public health facilities, and as a result, unintended teenage pregnancies, and even mothers even having also kids they had not planned for. So I want to know what measures is the Health Committee at the National Assembly making to ensure that we reverse this negative trend? Thank you.
Okay, thank you. I can take one more briefly. I don't know where the other microphone is.
Yes.
Briefly, and then we get the microphone to the back.
Thank you, Maura. My name is Austin Odur from MNH Coalition. My question goes to Dr. Mwangangi, the CS. My question is about the youth serving organization. What is the government planning for the youth serving organization, which it's a key role in our public sector? Most of when you walk around the country, most so Nairobi, most youth serving organizations are run by the private sector. But this one is serving a very key role that will help the youth so that it reduces the teen pregnancy. Thank you.
Thank you. That's brief. Thank you. We'll get the microphone to the back and get more. PS, I believe your mic is now okay. Please
is it okay?
Proceed.
Okay, thank you. I did mention earlier that before devolution, the distances to healthcare services was a bit further. So I think there's a bit of improvement. Like now, the devolved units are able to undertake some issues in ASAL counties. If I may take an example of Turkana County, somebody who was seeking treatment was to drive all the way from Lodwar all the way to Moya Teaching Referral Hospital in Eldoret. But as we speak now, there is a lot of improvement in the health services. So those people who are around Lodwar area or in Turkana, they can access medical services. And also most of the health facilities are equipped in the ASAL counties. Some of them are equipped than it was before. So I think we can say if there was something that in the area of the medical care, if there was an impact in this country, an area which had an impact of devolution in healthcare is the arid and semi-arid lands. So I may just give that as a summary.
The impact has been seen. Dr. Mwangangi, too many questions. Yep. Pick a few, give us a few responses, and then we'll get a few more thoughts.
Thank you. Good questions, all very relevant to our discussion. To the lady from White Ribbon, really I share your passion and your anger and your angst in terms of the health system and what we can do to improve it. One, the role of community is center stage. And our apologies if we didn't mention that, but I can tell you the community is the locus of everything that we're doing. And one of the key things that we launched this year as a policy is the primary healthcare strategy. And the primary healthcare strategy essentially envisions a shift of care from tertiary care to the primary healthcare level. So this includes, amongst all the many things we've discussed today, ensuring that you have a healthcare worker there, you have the drugs there, you have the equipment there. But most importantly, that you actually have the community making decisions in that health center. And so a recognition of what we call health boards that consist of community members at the primary healthcare level. So a health center being managed by the community members, a dispensary being managed by its community members, all the way to the tertiary hospitals. And so these are some of the interventions that really put the community center stage. Beyond this, also, we do have the community health strategy. And the idea is that let us have that person within the village, within your neighborhood, who wants to partner and work with government to ensure that my community is healthy. And this is taking different formats in different counties, where we're having a certain woman, mother, father, young person, old person, who are coming forward, helping us with vaccinations, helping us with meeting women who haven't gone for their ANC clinics, helping us to move mothers to the health facility. So I can really, should I say, emphasize, community is at the center stage of this. Now, Peterson, my friend, we've worked a lot with you in the ministry, and I do hear you when it comes to human resources for health. We need more doctors, we need more nurses. This is a situation that, is not only specific to Kenya, it's the world over. Having human resources available is a challenge that governments continue to face. But I must commend this government. In the age of COVID, within 1 year, we hired 8,000 new UHC 3-year contract staff. We hired about 2,000 interns who are to work under the UHC banner. And yes, there have been challenges. Right now, I know the UHC interns watching will ask you, are eager to ask me whether we are renewing their contracts.
They have already asked.
There we go. So those are the questions that we are expecting from the workers, and I will give you a response to that. So for the first time ever, when we look at that needle, that compass there, it moved. nearly 10,000 healthcare workers hired within 1 year. Can we do more? Yes. Dr. Nyikal has said we need to manage them better. We need to ensure the ecosystem is friendly to work in. We need to ensure they're equipped, they have the tools that they need, and also that we also take care of their mental health issues. So these are all things that we are working on when it comes to the HRH strategy. And I must say another little facet comes into play when we look at the curriculum. I'm sure as a practitioner, you may appreciate what has been raised here today on quality of health services. If you asked me, as Kas Mwangangi, what is the unfinished business as we move into the next government? It is quality of healthcare. We've done a lot in laying foundations, but it needs to be all put together in a way of asking ourselves, is this healthcare of good quality? And one of the things that comes into play is our healthcare workers fit for purpose. We have fantastic doctors, nurses, but are they all fit for purpose as a team, working on one patient? And so we will be putting together a curriculum conference very soon, and you're all invited. And these tough questions will be asked. Why do we have different diagnoses between two doctors, between two nurses? Are we actually treating our healthcare workers? Are we actually training our healthcare workers well? Now, the third thing, which is really important, is on GBV, because the questions are so many, and so I'll wait for my next round. But on GBV this year, our president made a very bold proclamation when it comes to the resourcing of GBV. One, we aim to ensure that we have reduced rates of GBV by 2026. And that's a commitment he made on a global stage. And how he intends to do this is, one, we shall allocate more resources to GBV issues. We'll start with about 21 million USD, aiming to get to 50 million USD by 2026. Number two, for the first time ever, $1 million each year will go to research for GBV. So that means all practitioners, all universities, academia will be able to give us fresh new evidence on that. Three, integrating GBV with other sectors. The polycare clinics you've heard of, where you have a police center and a health facility, those will be more, and they'll be scaled out within the country. And so there's tangible steps, and I must say I'm quite proud of what His Excellency was able to do when it comes to GBV. We are one of the frontline countries who've actually put our mouths and money together when it comes to GBV. And so we'll be looking to see, and PS, I know this is also part of what you do in executing the strategy that the President has laid out for us.
Okay. In the interest of time, we'll have to stop there. Although some would want to know when we'll see you, CS Kagwe, and others queuing at Kenyatta.
Thank you. In fact, I was waiting to get that question.
Your annual medical checkup.
Just this year, 4 of my family members have been admitted at Kenyatta National Hospital. I can tell you, I know the nephrologist there, the cardiologist there. They're all fantastic doctors. And I was even saying, if I deliver a child next year, why not Kenyatta?
Okay. All right. Okay, Dr. Nyikal, I'll give you a chance to respond. I have 2 questions at the front. Then we are going to send the microphone all the way to the back. So I need the technical team here ready to get the mics to the back, because I know we have many questions. Let's hear from Moses. Let's start with you. Briefly, please, in the interest of time.
Thank you. My name is Moses Kilonzo. I'm the chairperson living with disabilities, Lower Eastern. I have 2 questions. My first question is about special places in that. Like, take for instance, Mavoko constituency or Athi River. It's an industrial town. And, different counties in terms of health have different, preferences. So take, for instance, when we talk of Athi River, because of the industries, there are so many, chronic respiratory diseases because of the pollution there. It's totally different from maybe counties like Isiolo. So my first question goes to CAS. When you are dispersing monies to these counties, do you even when you are sending medicine to all these hospitals, do you look at these special places that need specific drugs? My second question is about NHIF. You correctly said that the government is working to ensure that NHIF is compulsory to everybody. But my question is based on a story that ran on Citizen TV yesterday, and I'm glad Wahiga is here. He did the story. It's about a person who was detained detained in an hospital, not because they didn't have the NHIF card, but they correctly said that the NHIF only pays for bed. So when you are telling us that the solution is with having the NHIF card, and yet a person was detained in hospital because of even when they are having the NHIF card, then I don't think you are offering a solution. So we need a concrete solution.
Okay, thank you for that, Moses. Let's get another. Please briefly introduce yourself and then a question or comment.
Thank you. My name is Joshua Muteti. I come from the National Taxpayers Association. My first question is that we have had 4 counties that were a pilot UHC implementation to test how UHC is going to be implemented. Do we have a research data that is informing on the performance and that will inform also on the implementation or the outline of the UHC in other counties? Number 2, we are at the situation where, as taxpayers, we are worried about the debt that is, we are a debt-driven economy. And as the country, as the government is extracting the taxes, we're expecting the service delivery in form of healthcare. Recently, we have done a research on opportunity cost, and we've assessed that when the country is extracting the revenues to facilitate the servicing of the debt, it's like it's an economics opportunity cost analysis. When you're spending on one thing, it means that you're underspending on another thing. I want to ask the parliamentarians who are seated here, how is the performance of this budget looking at the debt servicing? Are we at a risk whereby we are losing the resources towards servicing of debt as taxpayers, rather than paying the taxes, expecting the service delivery in form of taxes?
Thank you. That's a good question. Let's get 2 more from the back, and then we'll get responses. Go ahead.
So I have a quick question and a concern, and I wasn't actually going to ask a question, but I think it would be a shame if we went without discussing the fact that we have community health workers in the room who spend countless hours in our communities on the front line, risking their lives in many cases because they don't have PPEs, sometimes the proper training. Many times they're going at night without protection, and there's a risk of GBV. And we've heard for years there's plans to facilitate them, to train them, and to pay them. But and there's some progress in Nairobi County, but at what point is this going to be a national sort of priority so we can have our CHVs paid? My concern is also on this issue of allocations, because if we actually factor in, as my colleague said, the debt repayment that we're doing, health allocations this year are actually around 3%, not 6%. And if we look at 2017, our mental health allocations were 0.01% of our entire budget. So how are we supposed to sort of achieve these, universal healthcare, this affordable healthcare, without actually putting money into these programs?
That's a good 2 questions. Let's get one last one.
Hello,
I'll give you a chance. Don't worry. You go ahead and please introduce yourself.
Hello, my name is Sophie Kimeu from Kajiado. I was also concerned about community health volunteers, because I'm one of the volunteers in Kajiado. What will be our role in the universal health care?
Okay, thank you. I'll come to you just now. Let me get Dr. Nyika. Let me start with you. As the health committee, you scrutinize the budget that then the health ministry then implements. 3%, I think, of our GDP. Can we really say we are on the right track if that's the kind of money we are allocating? And you can correct me if those figures differ with what you have.
Well, I thought now we should probably be talking about 4 to 5% of the GDP, with per capita expenditure of about $88 or $90. But even having said that, it's still less than what we need to do. And I can tell you, way back 2003, when I was in the ministry, there's always been this war of increasing the expenditure on health. And it's a battle we always have when you come to the budget session. And you remember in the budget, during the budget period, they are all competing. There is the health committee, there is the infrastructure committee, there's the education committee, there's the security committee. So we are all fighting over the same cake. But I think there's a general agreement we should do it. We haven't reached there. But about about the other things, I want to say something very basic. You know why we are having, like, it looks very difficult? Because we are taking things one by one instead of looking at a whole system. Now, if we start looking at diseases, we start looking at diseases, gender-based violence, HIV, and so on, then we actually miss the point. The point is that if you have a system that is working and you improve that system, then you should actually be able to take care of all these things. And it works this way. Let's talk of primary health care. And if you think of it, you are talking about level 2 dispensary health centers. But the real beginning is the community. Because people don't get sick in hospitals. People get sick at home. And that's where we should look. And in this country, we have a community strategy that we actually wrote in 2004. I remember that. And it defined community health workers, and we planned, and it is going on, it's going on slowly, that we have the whole country divided in community units with community health workers. But although now you are calling them community health volunteers because we are afraid of paying them, I would call community health workers and pay them. And pay them. Because the community health worker is in the community and actually should be trained on everything about health at the primary level. You see, they are what we call the causes behind the causes. If you have cholera, we have a bacteria known as Vibrio cholera that makes you have cholera. But you are getting cholera because you don't have water. So water is the cause behind the cause of cholera. A respiratory illness, you are in a factory. You get chest infection or chest problem, even if it's pneumonia. But it is where you are working which is making the bacteria now infect you. So the cause behind the causes, social determinants of health. So that is where we started the community health workers. And I think we should do it. It is coming up, and that's what we should do. Then they should be, then when we have said those community health workers, they should be trained, and I think there's a plan for training them on all the aspects of health. And you should define, and we tried actually, you have a document in that ministry. We defined that at every level, what does the community have? And the community, human beings are not the same. A baby is different from a 5-year-old, is different from an adolescent, is different from a 25-year-old, is different from a 70-year-old who has prostate. So all these people, they exist in the community. So at every level, you must define what is it they need. I'll just give you a simple example. If you are a 70-year-old and you go to a community health worker, and your problem is that you are passing urine, you are passing too much urine, the community health worker should ask you, is it a lot at a go, or is it small amount you are passing frequently? They should have to know that if it's small amount you are passing frequently, it is prostate. So she knows where to take you. If you are passing a lot of it, at the go you are probably dealing with diabetes. They should know where to take you. So that community health worker, I think, is going to be a very important person. Then as you move up the level, when you now start, and that is where you know, if you eat too much fat and too much sugar, you are going to be obese and you are going to have hypertension and diabetes. That is not too hard for a community health worker to understand and tell you, why are you getting ill? And mental illness is, the big problem is there is stigma. And 2, there's a big thing. A mentally ill person does not know they are sick. They lose insight. So they don't go to seek help. A community health worker should know that before they even get to the hospital. Now when we get to a level where now you have left the community. And the community health worker should know what is the water, the water like in our river. You know, there are too many pooled ponds here, so the mosquitoes are around there. You are dealing at that level. That is prevention and promotion. Then when now you start getting into the curative health system, then again, we should talk of systems. What are the systems? Infrastructure, the buildings that are there. So at every level, there's a kind of building you need. In level 2 or level 3, what building you need. And then what staff do you need there? Then what supplies do you need there? And not only that, what diseases can be treated there? And these diseases must say, what I was telling you is a life cycle approach to health care. So that a baby at every level, what does a baby need? In level 2, what does a baby need? In level 4, why would a baby have to go to Kenyatta? So if we do that, and we're trying, there is KEF. We have something called KEF. Yeah, we started in 2004. I don't know what happened. So then at every level, it is defined. So it's like you have a book, a package of care.
Okay.
Now, when you go to financing...
Briefly, Doc.
Yeah, when you go to... Health can't be brief. So when you go to finance, next time what you should do, let's start at noon and we go up to 6. Let's start at noon and go up to 6. So when then you then go in financing, if you have put everything that somebody needs, all the people need, you see, if you take a 13-year-old person, a 13-year-old girl who suddenly is bleeding, the thing they should know is that this may be menarche, the first thing. You know, so that is something that the health worker should know, in the dispensary they should know. But if you have an 8-year-old lady who stopped menses and now bleeding, now you are talking of cancer.
Okay.
So this, let me just finish. I'll finish.
Okay,
so
good,
we should look at, when you have put all together, then how do you finance them? After you have financed them, who then is looking after them? After you have looked who is looking after them, what are the supplies you need? Our greatest failure now, challenge, let me call it, is actually infrastructure. We are doing well. But human resource management, that's why I cried. When doctors were dying, people asked me, Nikal, why are you crying? And I told them, if you do not understand why I'm crying, then this country is dead. Because if the people who are taking after other people are dying and they don't have PPEs and nobody's giving them insurance and nobody's... What was that young man whose father was looking for 200,000 shillings to admit him in ICU where he was working? So then human resource is our biggest challenge, supplies is our another challenge, healthcare financing is our other challenge. If we sort out those three, then we don't have to go gender-based violence, mental illness, and then, all diabetes and so on, because we will then have a system that looks after all of them at every stage until you leave this earth, from the day you came in to the day you leave this earth. And that is why I think we should finance this through insurance.
Okay. And on that note,
let me tell you, now this is the last.
We are taking a break.
And this is the last. And if you then do health insurance, then at every stage, you must have a package. What is it you will get for the money you have paid?
Daktari, can we take a break now? You've made your point. Let's take a break. You're watching give him a round of applause. I think he's made his points quite clearly. Let's take a break. We come back. Final comments from each of my panelists because our time is up, and maybe one or two questions, if time allows. We'll be right back after these commercials.